Hello everyone, my name is Pranav Sanapuram, and my presentation today is about challenges in treating older adults with cancer. I think one thing that's been instilled in us during this course is the notion that aging is a risk factor for a host of different diseases and conditions, including of course cancer. With a growing population, it's no surprise that there are more and more new cancer diagnoses occurring in patients above the age of 65. In fact, well more than half. However, the surprising thing about this is that there's been no real change in mortality in this older population. These patients are some of the most medically complex out there, and as such, it takes a team-based approach to do them justice. Not all oncology practices have the same resources that Vanderbilt does, and these older patients are far more likely to experience the harmful side effects of chemo, which makes close monitoring that much more important. Older patients can also be tricky because, as we've seen the last few weeks, their chronological age does not always correlate with their functional status. This slide shows a graphic showing the causes of mortality in adults above the age of 65. On the left, you have data from the 1980s, and on the right, from 2016. I think the striking thing about this chart is how much deaths from malignant neoplasms have increased, where deaths from diseases of the heart have actually decreased. And thinking about the major issues with geriatric oncology patients, I came up with 3 challenges. One being the lack of representation of the elderly population in clinical oncology trials. The second being the fact that treatment options like chemo, like surgery, like radiation, often exacerbate pre-existing conditions that our elderly population has. And the third being that many oncologists, because they're busy or for whatever reason, don't consistently utilize geriatric assessments. So let's start with our first challenge, the one regarding the lack of representation in clinical trials. An analysis performed by the Southwest Oncology Group by Dr. Hutchins looked at many different clinical trials within many different types of cancer. In this graph, the black bars symbolize what percentage of all individuals who have that type of cancer are elderly above the age of 65. The white bars symbolize the percentage of trial participants that were elderly and actually enrolled in these clinical trials. For instance, let's look at breast cancer. The black bar shows that 49% of individuals with breast cancer in the US are above the age of 65. However, these individuals only comprise 9% of participants in all breast cancer clinical trials. There are 2 exceptions to this, and they are within lymphoma and prostate cancer. The disparity is far less in these cases, 16 versus 14% in lymphoma, and 77 versus 64% in prostate cancer. And these findings have been confirmed by other groups, namely ECOG and Dr. Tallarico more recently. But why does all this matter? I think the first issue is drug dosing. It's difficult to apply pharmacokinetics to patients with reduced GFRs and varied volumes of distribution, especially when you're doing this in phase 1 trials. Additionally, with higher percentages of younger patients enrolled in these trials, there's often an underestimation of the treatment side effects. This brings me to the next issue, that older adults have a decreased functional reserve and are more adversely impacted by chemo, by surgery, by immunotherapy than younger patients. So all of this begs the question, can we actually apply trial findings to our older patients? So building off that last point, we know that treatment options that exist often exacerbate the comorbid conditions. When you're diagnosed with cancer, you'll generally be given radiation, chemo, immunotherapy, surgery, or some combination of those options. In those with liver disease, kidney disease, we have to alter the doses of chemo that we give. But remember, we don't even know what our standard doses for these older patients should be. Furthermore, we know that bone marrow reserves generally get lower as you get older, and therefore the hit to the red blood cell, white blood cell, and platelet cell lines are even at greater risk, and these patients can suffer even greater consequences as a result of this. Heart disease can affect everything about drug delivery. But one thing I didn't realize is that in patients with hypertension who then receive anthracyclines, they had an increased risk of developing heart failure. Older patients often have reduced pulmonary function, whether from COPD or something like that. But adding radiation agents, bleomycin, something on top of that can give these patients a much greater risk of mortality secondary to pulmonary fibrosis. Our greatest challenge, our last challenge, is the lack of routine usage of geriatric assessments. Geriatric assessments are essentially a tool to capture information that's specifically tailored for our older adults. I'll go into the details of the domains on the next slide, but here you can see some of the barriers to routine implementation of the GA, namely lack of time, lack of one standardized tool and one standardized way to score that tool, and a shortage of geriatricians to help oncologists, especially in community settings. These barriers have led to difficulty in incorporating GAs into routine oncology care. However, Grant Williamstown and UAB created a shortened version of the GA, which was quicker, and I have that listed on my next slide. So here we see the domains listed on the left-hand side. In the middle column, we have how that provider will be testing that domain. And on the far side, we have how patients themselves will be assessing that domain. I like this model because it limits what the provider has to do to essentially three things: a timed up and go, a Karnofsky performance scale, which is an assessment of functional impairment that's routinely used by a lot of oncologists, and a BOMC, which is very similar to the BCAM. The other pieces of information can actually be filled in by the patients as they wait in the waiting room or later on, and this includes an assessment of ADLs, number of falls, number of medications, etc. I think the biggest reason for using the geriatric assessment, in my opinion, is that it actually changes the treatment plan in 1/3 of cases. This is a very big deal, as it shows that sometimes even an experienced oncologist misses vital information when making their tailored plans. The GA is a very, very important tool, and for other reasons is that it's predictive in nature. It can predict toxicities from the treatment. It can actually even predict morbidity and mortality from treatment options, which during an initial oncology visit, that's kind of where the patients and the patients' families' focus is. Thank you so much for listening. These are my citations, and that concludes my presentation.